Welcome back to Life, which stands for Longevity Insights for Everyone. And I'm Dr. Lucy Hooper. I'm a GP and a doctor for many, many years now. And on this podcast, we are really trying to share our knowledge and the latest science and medicines and breakthroughs on how they can help you live a longer, healthier life. And I say we because it's not just me. I'm also very lucky to be joined by Dr. Hugh Coyne.
Hello, I'm Dr. Hugh Coyne, and I am Dr. Lucy's partner in this clinic that we run together, but also your husband. And we have two children together, two amazing children, which we're very lucky to have. And today we're diving into something that sounds a little bit technical, but is one of the most powerful predictors of heart health. What are we talking about today?
We are talking about apolipoprotein B or ApoB.
ApoB, yes, one of my favorite topics to talk about.
Yeah. And I really should disclose at the beginning that you have been talking about this for a long time.
No, I've been going on about ApoB for years.
4 years.
Nobody's been listening to me.
No one listened to you.
Literally till we started this podcast, yeah.
No one listened to you until a few years ago. I came round, I saw the light, and like all great revelations, I am now even more of a fan and devotee than yourself.
Yes, and you're very evangelical about it.
Exactly. Okay, so maybe start with telling people what is apolipoprotein B, or we will use ApoB for short because it's a bit of a mouthful.
Well, I suppose before we talk about what is ApoB, it's important to talk about cholesterol.
Yeah.
Right. So one really important concept that lots of doctors don't understand, and therefore lots of members of the public don't understand, is that the cholesterol in our body is all the same. It is all the same type of molecule, but it is how it is packaged is different. And some cholesterol is packaged in an apolipoprotein B.
Yeah, so I'm going to go back even further, back a step there, I think, to help people understand. So cholesterol is a fat.
Yeah.
It's a kind of fat. And just like you learnt at school, oil and water doesn't mix.
They don't mix.
And our bloodstream is mostly water, or watery, shall we say. The plasma, it's a water-like substance. And when the cholesterol needs to travel around the body, which it does, because even though it's sort of got negative connotations, all our cells use cholesterol.
Yeah.
We need
cholesterol is vital for life.
For life, yeah. Exactly. Some poor people who are born with these really rare conditions where they can't make any cholesterol and things like that, they have enormous medical problems. They're really dangerous. So we need cholesterol. All our cells use it. We need it for hormones. We need it for all sorts of purposes in the body. So that means it needs to travel around the body. And it travels in the bloodstream. But because oil and water can't mix, it can't just float around in the bloodstream. It needs to be packaged up. And so we get these packages where you get a kind of center of cholesterol kind of all packaged together, and sometimes some other kind of fatty molecules like triglycerides. So you get a little ball of those, and then they get coated around the outside like a Ferrero Rocher or a cream egg. They get coated around the outside with these proteins, which are called apolipoproteins. And the whole package, the whole Ferrero Rocher or cream egg, the whole package, so the cholesterol center with the proteins around it, that's called a lipoprotein. Yeah. I should say that when they were naming these things, I think they never imagined that we would have to explain any of this to patients. They were named by the, chemists and scientists. I don't think they ever thought, because the naming, I think, is not terribly helpful, but there we go. That's what we're left with.
I think the naming is is unhelpful and is confusing. I think it's slightly confusing how it's taught in medical school as well.
Yeah.
So we have these phospholipid cores, so made up of cholesterol and triglycerides and cholesterol esters, and then the surrounding of the Ferrero Rocher. I like that analogy. Like the coating of the Ferrero Rocher is an apolipoprotein B in some instances, and an apolipoprotein A in other instances.
And other proteins. And the reason why that outer coating of these proteins is important is because they are water soluble. So once the cholesterol is kind of hidden in these, it then can float nicely through the bloodstream and get to different parts of the body. And I think that's the important bit, I think, to go back to what you were starting talking about, is that the packages are different. So, you know, we have some cream eggs, some Ferrero Rocher, some, I don't know, mini eggs. I don't know. I'm trying to think of other egg type.
Coated confectionery.
Yeah, other egg type things. But the center actually is the same. That cholesterol in the center, there's no different kind of cholesterol. There's no like good cholesterol, bad cholesterol in those terms. Like the cholesterol molecule, like if you were to look at it under a microscope, it's exactly the same. And I have to say, I think that is a bit that does get lost on a lot of people. And I have to say, you know, we're just as culpable, because for years we did talk about like good and bad cholesterol, and perhaps without a full explanation of what we were talking about. And so it's really got ingrained in people's mind. And
on a very superficial level, it kind of works.
Kind of true,
But there's an important nuance. There are exceptions that don't prove the rule. Actually, there are exceptions that are really important to note. I suppose the other thing to know about why ApoB is important is because it is ApoB containing, or particles that contain cholesterol but have ApoB on the surface that go into the wall of the artery and cause an inflammatory cascade that leads to the production of a plaque, which then ruptures, and that can lead to heart attacks or strokes.
Yeah, I think maybe to go through that a bit more slowly, because I think it's really important, and it's a bit a lot of people don't get, is, you know, that your cholesterol in your bloodstream, most of the time, does very little harm to you. You know, it's not a bother to the body. You know, sometimes when it gets very high, it can, but for most people, it floating around your blood is not the problem. The problem is that when you get one of these particles, so now we've got this nice mental image of this little, you know, clump of cholesterol coated in proteins, and some of those, what we call particles, some of those, you know, little eggs will have this special protein called apolipoprotein B. So those ones with the apolipoprotein B, and that's the really important point, it's only these ones with an apolipoprotein B on the surface. These are the ones that then get into the walls and start to cause those blockages. And, you know, and what happens when you get one of those blockages and then they burst? What happens if it's in the blood vessels around the heart?
Yeah, so when one of these plaque ruptures, the surface is rough, and it means that platelets stick together, they clump, or as we would say, they aggregate on the surface, and it's that blocks the artery. It's not so much the plaque itself, it's the rupture and the response to it, or the cholesterol.
You know,
it's the response to it. It's the body's response to it. And you hate this analogy, but I love it. And it's the stag do analogy is the one that I often use, predominantly with my male patients. But just to explain why cholesterol is like a stag do in my eyes. So if you think again that the cholesterol molecules are all the same, and they are like people, we're all essentially the same. And like people, cholesterol molecules hang around in groups. And I think of HDL, which used to be termed the healthy cholesterol. HDL molecules don't have an ApoB in the surface, they have an ApoA.
Yeah.
And they're a group of cholesterols hanging around together. And I think of them as being like a group of people hanging around together in a city. And if you think of the city of having streets that are lined with bars and clubs, and HDL are like a group of cruise ship tourists wandering around a city street. They don't go into bars and clubs. So if you think of the bars and clubs lining the city streets as being like the lining of our arterial walls. So these cruise ship tourists, they walk around, but they have a guide. They have a guide with a little flag that walks them around the city and shows them the sights, but they don't do anything. They don't go into any bars or clubs. They just wander around. And if you have too few cruise ship tourists in your city, it means that your city's a bit naff. It's not great. And if you have too many, it makes your city a bit naff. And that's very much like HDL. You want to be just in the middle, not too much, not too little,
Goldilocks.
just right. Goldilocks molecule is what I call HDL.
Yeah.
So if the ApoA containing molecules are like a group of cruise ship tourists just wandering around, the ApoB containing molecules are more like a stag do. Now, the reason why they're like a stag do is because they are, again, a group of people that goes around a city. But this group of people goes into the bars and clubs. But a group of men cannot get past the bouncer on a door. No bouncer is going to let 20 men into a club. So the best man has to pay for a tour guide to get them past the bouncer on the door. And in the body, this tour guide is apolipoprotein B. That's what gets the cholesterols past the bouncer on the door, gets them through the cell lining and gets it into the lining of the artery. And in the stag do analogy, it is the tour guide that gets the stag do into the bar or nightclub. And it's in there that they cause the damage because they get pissed, they wreck the bar, and then trouble starts and it spills out into the street. And then it's the response to that that causes the problem. And the police are called and the street gets cordoned off. And that's kind of like having a heart attack.
Yeah, okay. I've heard this analogy before. I have to say...
you still don't get it?
I still don't. I do get it. Get it. But maybe it doesn't speak to me.
It doesn't resonate with you. You haven't been on enough stag do's.
I have not been on enough stag do's. I think you have, though. But I have not. I have not. But I think the message is that all the harmful cholesterol is to be found in these particles that have a single apolipoprotein B on their surface, like a little tag, it's like a little tag saying, this is all the bad cholesterol is to be found in these ones that have this, this bad tag on. Yeah.
And we should probably talk about when we are measuring people's cholesterol, we measure their total cholesterol.
Yeah.
And then their HDL is measured. I don't like
HDL cholesterol.
I don't like using the term HDL cholesterol because the cholesterol is all the same. It's just measuring the lipoproteins.
Yeah.
So it's HDL is measured. And then from that, a calculation is made.
Yes.
And they derive a calculation of the concentration of LDL and non-HDL. And the way I often describe that is LDL is the most important molecule that goes into the wall of the artery and causes cardiovascular disease. And non-HDL is all the molecules that go into the wall of the artery and cause cardiovascular disease. And each one of those molecules that can go into the wall of the artery has one apolipoprotein B on its surface. And we can get a more accurate measure of the number of cholesterol-containing particles that can go into the wall of the artery and cause cardiovascular disease by measuring apolipoprotein B.
Yeah, so we can count, we can count how many of those little eggs containing cholesterol, how many of them have got that nasty apolipoprotein B tag on their surface. And if they don't have that on them, they're not going to cause atherosclerosis. They're not going to cause blockages, heart disease, strokes, those things. So by counting the number of apolipoprotein B particles, we can have a much, much clearer idea of, is your cholesterol going to cause you a problem?
Yeah. Yeah. And how do people do that test then?
So, it's actually, a relatively simple blood test, as in, you take it just like we take any other blood test at the doctor's. You don't need to fast. So you don't need to worry about that. You take it any time of day. You can take it for people who are on medication, say, that might lower their cholesterol or not. And we do it all the time here. It's not routine in NHS care. And I think it's pretty rare for people to have it checked. In other countries, it is becoming more and more common. In the USA, it would be part of a lot of lipid panels, as they like to call them, a part of a lot of testing. But it is much more available now privately in the UK. And, as tests go, it's not a super, super expensive. It's not a test, even if you're funding it yourself, if you're paying for it, it's not something that costs hundreds of pounds even, so it is accessible and available for a lot more people now.
Yeah.
So what would you call a normal apolipoprotein B level?
Okay, so I would, instead of thinking about what would I call a normal apolipoprotein B, I would talk about a desirable and an optimal apolipoprotein B. And I think in terms of the units that we use, an apolipoprotein B of less than 1 is desirable and less than 0.8 is optimal. And for people who are at risk of cardiovascular disease, so for example, people who might have high blood pressure or diabetes that might be increasing their risk of cardiovascular disease, I would be trying to get them to aim for a target of less than 0.8. And for people who are at lower risk, I would be saying to aim for a target of less than 1.
Yeah.
Now,
so I'll just go back a sec there. So you mentioned, the units we use. So our laboratory measures in grams per litre. And that's a measure of the actual amount of apolipoprotein B, the amount of particles. You will sometimes see other people might have lab results where the units are different and they're not comparable.
Yeah.
The gram per litre measurements is preferable as more precise, more accurate measurement. But other people might see, especially maybe some older results, where it's measured in different units.
Yeah.
And those numbers might look different.
And we should probably mention about why we think measuring apolipoprotein B is better than just a standard lipid panel.
So it's really because of this factor of discordance, So, that, and what we mean by that is that for a lot of people, the apolipoprotein B level will roughly match how much non-HDL cholesterol they have in the blood. So, how much LDL cholesterol roughly, say. So, but for some people, there will be what we call this discordance, and that's probably about 20% of people. And what that means is that these people might have lots and lots of these tiny little eggs, each with an ApoB on the surface. And so if you measure their ApoB, it will be high. But because the eggs are quite tiny, they're kind of these what we call small, dense particles. Because they're quite tiny, their cholesterol, if you're just looking at normal, regular blood tests and measuring their LDL cholesterol, that actually might be quite low. So you can be falsely reassured by that. And that's where this discordance comes from. And the opposite is true. So you can have people where actually their cholesterol numbers look quite bad. And you think, gosh, this is a bit worrying. This person's not very healthy or at high risk. But then actually you check their apolipoprotein B and actually it's pretty low.
Yeah.
And then those people like get it the good way around. So they're actually at lower risk.
Discordant at low risk.
Yeah, than you'd think from
Yeah.
just looking at the cholesterol alone.
And I should say that in terms of which is better to check, the non-HDL or ApoB, that's still a relatively contentious area in medicine and in cardiology. And there are a number of studies that have looked for this. So in genetic models where they've used a technique called Mendelian randomization, which is looking at people with specific genes that code for a certain issue, like having high non-HDL or high ApoB, and they follow those people. The non-HDL is a more accurate predictor of heart disease than ApoB. So if you have non-HDL and you add ApoB to that model, there's no improvement in the risk calculation. But if you checking ApoB and add non-HDL, that leads to a big improvement in risk prediction. But there are other studies, cohort studies, for example, that suggest that ApoB is a better predictor of cardiovascular risk. And two massive studies, which were InterHeart and AMORIS, found that the ratio of the apolipoprotein A, which is all the HDLs, if you like, to apolipoprotein B was the most accurate risk marker for cardiovascular disease. And there's also been studies that have shown that apolipoprotein B is the best target of treatment. So when we are treating people, that apolipoprotein B gives us the most accurate answer. So for me, the whole question of should you check non-HDL or ApoB is a complete nonsense, because ApoB is not a very expensive test. It doesn't require any more interventions. It's the same blood test. You're using just one needle. If the patient is seeing you, or that might have several attempts to get in the blood taken out of them if they're seeing me. But it's the same. It's the same test. It's just the doctor ticking another box. And I think it's much better to check both, because some people are particularly at risk of getting this discordance, aren't they? So it's people with metabolic syndrome, people with diabetes, or people who have high triglycerides are much more at risk of discordance, and it's important to pick those people up.
Yeah, exactly. And it has been very powerful in studies looking at how you can look at a group of people, especially people that are already on medication for cholesterol. There was a really big study looking at those people in 2021, and that really showed that the group with the raised apolipoprotein B had massively higher mortality rates and risks of a heart attack than the group who had low apolipoprotein B. So I think that's why it's really helpful.
So if someone is there and they've had a standard lipid panel with their, say they've had their NHS over 40 check and they've had their total cholesterol checked, and their doctor said their cholesterol is normal, do they still need to do the test?
So I would say yes, because I'm all for, having the most data we can to making decisions. Most decisions are better if we have more data to help us decide. So I would say yes, but I would especially, strongly advocate it for people who have other risk factors. So yes, of the people with metabolic diseases like diabetes, prediabetes, people who have known cardiovascular disease, like a history of heart attacks, strokes, mini strokes, or people maybe with a strong family history of those conditions. And that's because, again, like you want, in those situations, you already know your risk is higher. So we want as much data as possible. And that's when it can really help as well in terms of deciding next steps. deciding perhaps, are you going to stay on the same medication for your cholesterol? Are you going to change? Are you going to, try and increase the intensity of your medication regime to try and lower cholesterol further? And, having that data can help make a decision.
Helpful. Yeah. What about if apolipoprotein B comes back high? What next?
What next? What do you do? So it's like you say, it's one factor. It is really, really important factor. Don't get me wrong. And it is, but it is still one factor that we need to weigh up in the kind of landscape of that person's risk profile. So by that we mean other things like blood pressure, BMI or body fat. Are they a smoker? What's their family history? What's their personal history of illness? And, all those things together, we can then use to build up a really detailed risk profile for that person, and then decide, okay, is the risk high enough that we need to tackle apolipoprotein B? And, if we do, what's going to be the best plan for that person? So, that might go, all the way from, talking about nutrition and exercise and weight management and things like that. And then further on to, two medications that work. So we know, statins, so these lipid lowering therapies, statins will reduce your apolipoprotein B. But obviously we don't just have statins now in terms of cholesterol lowering. We've got lots and lots of other medicines, ezetimibe, bempedoic acid, PCSK9 inhibitors. We've got lots of medicines we can use and tailor together for an individual.
And I really like using, for people that require medication, this is, and where, say, a statin isn't quite enough to get their apolipoprotein B into the normal range. The best evidence now suggests actually not just relentlessly increasing the dose of the statin, but actually to add in another lipid-lowering therapy like ezetimibe. So you've got two low-dose medications working on different points of the LDL production pathway. So they're acting synergistically to lower people's lipids, but because they're at a low dose, people are not getting the unpleasant side effects that they would from just escalating the dose of a statin. And as you were saying there, the bedrock of it all is the lifestyle changes. And exercise you mentioned, so both strength training and endurance training and also HIIT are all fantastic ways to optimize your ApoB. Achieving normal weight, if possible, will really help improve ApoB. Diet is really important. So having a high fiber, high protein Mediterranean style diet with lots of oily fish, olive oil, nuts and seeds, leafy green vegetables, and having that as a sort of, I hate the word holistic, but that approach of thinking about not just the diet, but also the exercise and the weight and sleep and stress. All of those things are important. Now, stress is not going to particularly help people's ApoB, but it's going to impact on their risk of cardiovascular disease. So it's thinking about it more in the whole rather than just specifically about trying to get this really low ApoB number. And then obviously making sure that they have perfect blood pressure as well is really important. And so it's managing the whole picture is the crucial thing, isn't it?
Yeah, exactly. And I think that approach of using combinations of medications at lower doses is definitely the way forward. I don't think the UK guidelines have caught up with that yet. But definitely internationally, there's so much evidence now that you get better results. You get, lower LDL cholesterol, fewer side effects, happier patients. They continue their medications for longer because they feel well and they get good results.
Yeah, and they get much better. They get much better outcomes, don't they?
Yeah.
And then just to mention that medication that you mentioned before, bempedoic acid. So that's often one that we use when people are intolerant of statins. and often also use that in conjunction with ezetimibe as well. There actually aren't that many people that are completely intolerant of every statin because they go down different metabolic pathways, but that can be a really useful medication. And then the PCSK9 inhibitors, well, they're really groundbreaking, aren't they?
They are amazing, and their ability to lower lipids and to lower risk is amazing. And generally in the UK, we've been a bit behind the targets for cholesterol, i.e., the UK guideline targets for how low your cholesterol should be are quite high. They're much higher than they are in Europe or the USA. And that's because they were decided by this, this body called NICE. And so the reason the target was set at that level was not scientific, i.e. it wasn't chosen for what's the healthiest level of LDL cholesterol to get people down to, or apolipoprotein B. It was chosen as that was the most cost-effective level to get people to.
So we would often describe the main healthcare system in the UK, which is the NHS, is that as a value-orientated healthcare system rather than outcomes-orientated healthcare system that's focused on extracting maximum value, which it does actually really well, I think.
No, exactly. But when we're looking at it just as an individual, as a person, for most people, you want to actually be getting their LDL cholesterol a little bit lower. And therefore their apolipoprotein B, levels, importantly, a little bit lower.
If they're concordant.
If they're concordant, yes, exactly. So I think the main message about apolipoprotein B is that if you are someone who has been worried about your cholesterol, or if you're someone that worries about your heart health, which really is all of us, because cardiovascular disease is still the number one cause of death for us. So, really for everyone, that apolipoprotein B or ApoB testing might just give you that extra little bit of information or help you make a better decision to reduce your risk.
So should everyone have an ApoB?
Yes, I think probably I'm going to say yes. I think definitely as a true evangelist of lipid testing. Yes, because, I just said that cardiovascular disease, number one cause of death, but 80% of that is preventable. So if we optimize all these things like blood pressure, apolipoprotein B, lipids, if we optimize those, we can prevent nearly all of it, which is amazing.
It's extraordinary. And I think ApoB could be the missing piece of the puzzle.
Yeah, exactly. So I think it's a really useful topic. Hopefully people can learn a little bit more about it, hear about it, ask their doctor, talk to their doctor about it, find out about getting a test. And hopefully that's going to help people live healthier, longer, happy lives.
Amazing. Thanks very much, Lucy.
Thank you.